Welcome back to the deep dive. You've handed us a stack of sources detailing the diagnostics of, well, the human support structure, the musculoskeletal system. Our mission today is to really crack the code on its hidden language. We're
Little.
trying to go beyond just the glossary definitions and get into the real context. What does a silent nerve signal actually tell us? Why is one single number on a lab report a total five-alarm fire?
Exactly. This isn't a textbook reading. It's more of a targeted knowledge synthesis.
Hmm.
We're focusing on demystifying the core clinical assessments, the advanced imaging, and especially those critical blood chemistry panels that guide almost every decision in orthopedics, rheumatology, and trauma care.
So if you need to quickly figure out, say, whether widespread pain is from a nerve being compressed or a systemic muscle issue,
Or why a certain electrolyte reading demands you act now.
then this deep dive is tailored specifically for you. The goal is really to give you a powerful mental toolkit for connecting those symptoms to the core metrics of MSK health. Okay, so let's start with the groundwork. What can professionals learn just by looking and listening, before any of the advanced tests are even ordered?
Mm-hmm.
Our sources laid out this fantastic assessment grid that really focuses on those first clinical clues.
Yeah, and in a high-stakes setting, you have to immediately distinguish between problems of, let's call it structure, and problems of function.
Yeah, that's the core challenge, right?
It is. It's the core triage challenge. I mean, consider the simplest bone issue. Trying to distinguish a fracture from long-term osteoarthritis, or OA.
Okay.
A fracture is acute trauma. It's a breakdown of bone integrity. You see immediate acute pain, swelling, and often an obvious deformity.
Whereas osteoarthritis is a much longer, sort of grinding story.
Precisely. OA is fundamentally a failure of joint cartilage integrity. So instead of a sudden break, the clues are chronic.
Things like deep joint pain, stiffness.
Right, stiffness, especially in the mornings, and that unmistakable auditory sign, crepitus.
That grating or popping sound. It's
Yeah.
literally the sound of bone rubbing where that smooth cartilage used to be.
It confirms that failure of friction management. And if friction management is the issue in OA, then density management is the issue in osteoporosis,
A different kind of failure.
a totally different kind. Osteoporosis is a systemic reduction in bone strength. The core clue is low density, which is, quiet and painless until a catastrophic failure happens.
But those failures have to have physical signs over time, right?
They absolutely do. Low density dramatically increases the risk of these small, insidious compression fractures in the spine.
Little breaks.
Little breaks, exactly. And repeated microfractures over time lead to height loss and the characteristic posture change we call kyphosis.
Which is that pronounced hunch?
That's it, that excessive outward curvature. It's a signal of long-term damage because the compressive forces are just exceeding the bone's strength.
Okay, so moving beyond the purely structural, our sources also touched on conditions that measure pain processing, like fibromyalgia. This feels like a completely different ballgame.
That is a critical shift.
We're not looking at a broken bone or a worn-out joint anymore.
Not at all. Fibromyalgia isn't about structural damage. It's about how the body is processing pain and managing its nerve signals.
So we're assessing things like,
Widespread musculoskeletal pain, chronic fatigue, and tenderness in very specific muscle areas. It's a qualitative assessment of the nervous system's response.
which is light years away from assessing something like the plegias, where we're just measuring a failure of motor command.
Correct. Yeah, plegias refers to degrees of paralysis. When we're assessing conditions like paraplegia or quadriplegia, we're measuring voluntary motor function. Low might mean partial paralysis or paresis, where some movement is still there.
High is.
Complete paralysis, total immobility.
And finally, the grid in our sources included amputation, which, beyond the obvious loss of a limb, it brings a really fascinating neurochallenge into play.
It does. And that challenge is phantom limb pain.
Right.
It just demonstrates the brain's persistent reliance on nerve signals from a limb that is physically gone. The nerve endings are still sending sensory data.
Resulting in very real pain.
Very real pain. So this whole clinical snapshot moving from a bone breaking to this chronic nerve signal chaos, it gives us the essential groundwork. But to truly understand the chaos, we have to move inside.
And that's the critical bridge we need to cross. We're leaving the realm of physical observation and diving into the internal chemistry that dictates how well those nerves and muscles even talk to each other.
Okay, let's unpack this. Starting with the heavy hitters in biochemistry. We're talking about the critical electrolytes that stabilize every nerve and muscle fiber in your body.
Mm-hmm.
And we begin with magnesium, which I think of as the unsung hero, the brake pad for your nervous system.
That's a great way to put it. Magnesium is a quiet giant. Its job is stabilizing membranes, especially in nerves and muscles. And the normal adult range is surprisingly narrow, 1.7 to 2.2 milligrams per deciliter. And why does that tiny range matter so much?
Because magnesium regulates calcium movement. It basically prevents nerves from firing uncontrollably.
So if magnesium is low hypomagnesemia, the brakes fail and everything just goes haywire.
Precisely. A deviation of even half a point below that range leads to severe neuromuscular instability. You start to see muscle cramps, tremors, seizures, anxiety, even heart rhythm issues.
So the key memory point here is undeniable.
It is. Low magnesium equals twitchy, hyperexcitable nerves.
And the opposite, I assume, is just as severe, but it leads to a complete shutdown instead of hyperactivity.
Exactly. High magnesium or hypermagnesemia means the brakes are slammed on too hard. The body slows down excessively. We see decreased reflexes, profound muscle weakness, hypotension, and the really critical danger, respiratory depression.
Which is deadly.
It is, because it means the diaphragm, which is a critical muscle, is failing to contract properly.
Right alongside magnesium, you have potassium, the electrolyte known everywhere as the conductor of the heart's orchestra.
Yes. Potassium, with its normal range of 3.5 to 5.0, is essential for, well, for cardiac conduction. And like magnesium, the consequences of an imbalance are immediate and dramatic.
And that margin is just terrifyingly thin. It's wild how close 3.5 and 5.0 are. It feels like the difference between a slightly weak grip and full-on cardiac arrest.
It can be.
What are the dangers on that high end?
High potassium, or hyperkalemia, is one of the quickest ways to cause a life-threatening emergency. Levels above 6.0 can induce severe cardiac arrhythmias and rapidly lead to cardiac arrest.
Because it just shorts out the whole electrical system.
It disrupts the electrical signaling needed for a coordinated heartbeat. This is why we stamp this key memory point. Potassium equals heart rhythm.
Now, you mentioned interfering factors. We know that hemolysis, where red blood cells burst during the blood draw, can cause a false high reading. But beyond a simple lab error, what are some common medications or conditions that can massively skew those potassium readings?
That's a great question because context is everything. Many common medications, particularly certain diuretics and ACE inhibitors used for high blood pressure, are known to retain potassium.
Pushing the levels up?
Right. And on the flip side, things like insulin and some kidney conditions can actually push potassium into the cells, causing a temporary low reading in the blood. Knowing the patient's medication list is just as vital as the lab number itself.
That just underscores why the holistic view is so crucial. Okay, so let's pivot from these systemic regulators to the direct markers of trauma. If the muscles themselves are damaged, what's the earliest flag we see?
That would be myoglobin.
Myoglobin, the substance we test for when we suspect major acute muscle trauma, like in a crush injury or extreme overexertion leading to rhabdomyolysis.
It is the earliest indicator. Myoglobin is the oxygen-carrying protein in muscle tissue. When muscles are damaged, they just dump this protein into the bloodstream. High levels signal massive muscle breakdown.
And that can include heart muscle damage too, right?
Absolutely, if we're talking about a cardiac event. But this isn't just about identifying the damage, it's about the devastating secondary effects. Myoglobin itself becomes a toxic problem for the kidneys.
Yeah, that's what I was going to ask.
When myoglobin is released in huge amounts, the kidneys just struggle to filter it. The large protein molecules literally clog the tiny filtering tubules, and that leads to acute kidney injury.
And that dangerous cascade brings us neatly to creatinine and CK.
It does.
So creatinine, typically in the 0.6 to 1.2 range, that's our standard kidney filter check.
Right. High creatinine is the standard sign that the kidneys are failing to clear waste efficiently. It's the metric that tells us the filtering system is overwhelmed.
But then we also measure CK creatinine phosphoxynase. This is where we differentiate the source of the problem, right?
Correct. Elevated total CK tells us there's been damage to muscle, skeletal, or cardiac, or the brain. But the magic is in the isoforms, the subtypes of CK. For example, CKMM points to skeletal muscle damage, which is what we see in rhabdomyolysis. But if we see high CKMB, that's much more specific to cardiac muscle damage.
I see.
So by comparing the myoglobin, which is the earliest signal, the total CK, which confirms muscle damage, and the creatinine, which confirms kidney failure, we can instantly identify that classic life-threatening rhabdo pathway.
So the high myoglobin with the high creatinine is the immediate danger alert.
while the CK provides confirmation and context on the type of muscle damage. And the time-sensitive detail here is critical. Myoglobin rises fast, but CK levels often peak later and stay elevated longer, confirming the sustained nature of the injury.
That makes sense. And finally, when the problem is localized, maybe a knee or a shoulder, we stop looking at blood and we look at the joint fluid itself with erythrocentesis.
Yes, this procedure involves withdrawing synovial fluid directly from the joint capsule. Normally, that fluid should be clear and straw-colored with very few white blood cells and, critically, no crystals or bacteria.
So what key stories can that joint fluid tell?
Oh, they tells us everything we need to know about the local environment. Analyzing that fluid instantly detects bacterial infection, which needs emergency surgery, or the presence of uric acid crystals, which confirms gout.
Mm.
The key memory point is simple. Joint fluid tells the joint story. What's really fascinating here is how we transition from internal chemistry, the molecular language, to direct visualization and electrical function. This allows us to start pinpointing where the signal chain is broken.
And the best way to test that chain is with an electromyography, an EMG. We're moving from structure to function, testing the active conversation between nerves and muscles with those tiny needle electrodes.
The EMG is invaluable because it records electrical activity. In a healthy muscle, it should be electrically silent at rest.
And when you contract it.
The activity should be smooth and predictable.
Okay, but if the muscle is quiet at rest, how do you know a patient isn't just failing to contract? How do you mistake simple weakness for a true nerve problem?
That's a crucial technical point. We look for specific electrical characteristics called spontaneous activity.
Yeah.
If a nerve is truly denervated or irritated, the muscle membrane becomes hypersensitive and it fires randomly even at rest. You see these sharp waves or fibrillation potentials. That spontaneous pathological activity confirms the nerve is the source of the issue.
So it differentiates it from just weakness or non-cooperation.
Exactly. The EMG is critical for distinguishing between a muscle disorder, a myopathy, and a nerve disorder, a neuropathy.
Yeah.
And that distinction completely changes the treatment plan.
So that makes the EMG's key memory point pretty clear.
Yeah.
EMG equals the critical nerve-to-muscle communication check.
That's it.
So now we shift entirely from electricity back to structure, starting with the most universally available tool, basic radiography, the standard X-ray.
X-rays are the front line. They visualize structure, the shape, alignment, basic density of the bone. They're used to detect fractures, obvious tumors, alignment problems. It is the basic, quick look at the bone structure.
And that includes specific spinal radiography, right? Focusing on the alignment of vertebrae and degenerative changes.
It does, but we have to highlight the clinical caveat our sources emphasized here.
Okay.
Spinal X-rays are generally not recommended for typical acute back pain unless those symptoms are severe, neurological, or last 6 to 8 weeks.
Why is that?
Well, they're often unnecessary in the early stages, and they carry radiation exposure without actually changing the initial conservative treatment plan. We save that imaging for when we suspect a longer-term structural issue.
Okay, that makes sense. But if we want to know the quality of the bone, not just its shape, we move to bone densitometry, the famous degrate scan.
Right. The DEXA scan is all about prevention and prediction. It uses low-dose X-ray tech to measure bone mineral density, or BMD. The results are given as a T-score, which compares your density to a young, healthy adult.
And what's the goal metric there? What's a good score?
The normal finding is a T-score greater than minus 1.0. If you hit MENIC 2.5 or lower, that's a diagnosis of osteoporosis. This scan is the gold standard, and it's the single best predictor of your future risk for a fragility fracture.
So DXA equals bone strength measurement.
That's the one.
And finally, for a real-time dynamic view of bone activity and metabolism, we move from structural X-rays to the bone scan, which feels much more like a chemical test.
It is. This is a nuclear medicine test where a radioactive tracer is injected, and that tracer is drawn to areas of high metabolic activity. A bone scan is powerful because it often detects disease long before a structural change is even visible on a plain X-ray.
So what are we looking for on the scan itself?
We're looking for hot and cold spots. Hot spots indicate increased activity, think stress fractures that haven't fully broken the bone yet, deep-seated infections like osteomyelitis or cancer.
And cold spots.
Conversely, cold spots indicate decreased blood flow, which is a classic sign of severe damage, like a vascular necrosis, where the bone tissue is literally dying from a lack of blood supply. That's why the key memory point is bone scan equals dynamic bone activity and metabolism.
So what does this all mean? We have successfully constructed a pretty comprehensive knowledge map of MSK diagnostics,
Mm.
moving from that first physical clue to the chemical signal and finally to the electrical conversation.
And if you take away just 6 core ideas today, let them be these, because they represent the most critical triage metrics.
Okay, let's hear them.
First, magnesium controls nerve and muscle stability low equals twitchy. Second, potassium governs heart rhythm high is a cardiac
Got
emergency.
that.
Third, myoglobin is your rapid marker for muscle injury. Fourth, creatinine is your instant kidney filter check.
Okay.
Fifth, the EMG differentiates nerve from muscle problems. And sixth, arthrocentesis ensures the joint fluid tells the joint story.
And as we've emphasized throughout this deep dive, the real power is in seeing how these metrics collaborate or, collide.
Absolutely. The trauma scenario illustrates this perfectly. A high myoglobin level combined with a rapidly rising government. Creatinine immediately paints the full picture of
The
rhabdomyolysis,
muscle is breaking down.
and the kidneys are now failing. This synergy of diagnostics is what drives critical, life-saving intervention.
This entire system, from that initial clinical observation to the final lab result, is just incredibly time sensitive. Which brings us to our final provocative thought for you to mull over.
Hmm.
Our sources repeatedly noted that myoglobin levels normalize quickly, typically within 24 hours of muscle injury.
Right.
This raises a fundamental question. Considering this rapid metabolic change, what does this inherent time constraint imply about the necessity of immediate testing? And how does this biological clock shape the ethical and logistical decisions patient care teams must make after suspected muscle trauma? Something for you to chew on as you continue your deep dive.